afternoon, and welcome to Psychiatry Grand Rounds. There is no commercial support for today's program. The planners and speaker have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. A link to the event evaluation will be shared at the end of the program. It is my pleasure to introduce our guest speaker today, Dr. Justine Welsh. Dr. Welsh is a child, adolescent, and adult addiction psychiatrist and an associate professor in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine. She holds the position of Vice Chair for Child, Adolescent, and Young Adult Programs and serves as the founder and director of the Emory Healthcare Addiction Services. Dr. Welsh is also the medical director of the Addiction Alliance of Georgia, a collaborative initiative between Emory University and the Hazelden Betty Ford Foundation, and is the associate director for the University of California, Irvine Train New Trainers Primary Care Addiction Medicine Fellowship. Dr. Welsh completed a combined BS-MD program at Northeast Ohio Medical University, general psychiatry resident at Emory University School of Medicine, and 2 fellowships at Harvard University, one in child and adolescent psychiatry at Cambridge Health Alliance, and another in addiction psychiatry through Mass General Brigham. Dr. Welsh is an active advocate for expanding access to care for individuals with substance use disorders and implementing innovative ways to approach recovery. She is a former board member of the Georgia Department of Behavioral Health and Developmental Disabilities and currently chairs the Public Policy Committee for the American Academy of Addiction Psychiatry. Her research focuses on improving access to evidence-based treatments for substance use disorders across the lifespan. She has been the recipient of awards and grant funding from agencies such as NIDA, NIAAA, and AACAP. Dr. Welsh has numerous publications, including the co-edited book, Treating Adolescent Substance Use, A Clinician's Guide. Please join me in welcoming Dr. Welsh.
Good afternoon. It's an honor to be here. I was really excited to come out from Atlanta and to see the campus. It's absolutely gorgeous, and it was a lovely drive. So wish me luck driving back home. All right, so today we're going to be talking about substance use disorders in youth, and I'm happy to take any questions. I've been asked to hold them until the end. There we go. All right, and here's my disclosure slide. I don't think there's anything that's a conflict of interest with this talk, but we'll certainly let you decide. So our outline for today, we'll be touching briefly on the scope and the extent of substance use in youth. We'll then be covering some behavioral interventions and things that you can employ in your own clinical practice. And then we'll be covering medication management, focusing on opioid, alcohol, cannabis, and nicotine use disorders. So let's touch base on the epidemiology or the extent of the problem. So this here is data from the National Survey of Drug Use and Health. And for those of you who might not be familiar with that, it's a household survey of over 70,000 individuals here in the United States each year. This figure here breaks it down into DSM-5 diagnosis by substance use disorder, and it's excluding nicotine and tobacco. And the 2 things I really want to call out on this figure are the rates of substance use disorders in the past year in adolescents, which is 8.7%. But then when you look at the young adults, and these are ages 18 to 25, it goes up to 27.8%. That's between 1 in 4 to 1 in 3 young adults in the United States are estimated to have an active substance use disorder, excluding nicotine and tobacco. And just a quick show of hands, I mean, does this seem to fit with the population you're serving, for those of you who work with young adults? Yeah, I'm still surprised by this number, but I treat plenty of young adults, so I likely shouldn't be surprised at this point. This here is also from the National Survey of Drug Use and Health, and I just wanted to highlight that the vast majority of young people don't receive services for substance use disorders. And the vast majority who don't receive substances for substance use disorders don't receive them because they don't think they need them. And this is where motivational interviewing and early intervention and family supports and really engaging with patients in settings like primary care are just crucial to getting them wrapped into services. And we'll take a look at some of the prevalence of substance use disorders within patients who are experiencing other psychiatric symptoms, but that's also a point of intervention. So moving right along to some risk factors here. So we have a number of risk factors that connotate risk from early initiation of substances to progression to substance use disorder when someone's using, as well as some of the risk behaviors associated with substance use. So this slide is an oldie but a goodie, and it's from the NESARC data. And so that was a national study looking at alcohol use. And what we found was that in individuals ages 13 and younger who were exposed to alcohol, they had about a 50% likelihood of developing alcohol dependence throughout their lifetime. Now, this is a survey of over 43,000 individuals, and they did control for the amount, the years of exposure. So it wasn't based on the amount or how long they had been drinking. But what we now know are there are key structural and functional changes that we can identify on neuroimaging based on the age of exposure. So the brain, neuroplasticity, it's more adaptive and responsive to substances the earlier you were exposed. So if you start drinking at the age of 13 or younger, you have almost a 50% likelihood of developing a severe alcohol use disorder versus 9% in those individuals who wait until at least the age of 21. So when families and parents are asking me, what can I do to reduce the likelihood that my child is going to suffer from addiction or develop a substance use disorder, the number one thing is to delay the onset of use. And every year you are able to do that, it is protective for that child. We also have a number of other risk factors from family history. Above and beyond family history, if you have parents in the household or guardians who are using substances, that child is far more likely to engage in substance use themselves. I see plenty of parents who will attempt to kind of cover up their own substance use or hide substances in the household. Kids are very good at finding things, so just be aware of that. In utero exposure is also above and beyond a risk factor. So children who've been exposed to substances in utero, including nicotine, have higher rates of substance use disorders and an earlier age of initiation of using substances themselves. So when I'm doing a screen for family history, I am always asking about the potential for in utero exposure. Early onset of aggression, peer rejection, unsupervised time with peers. So when you're thinking about when do kids use substances, yes, they use substances on the weekends, but the highest risk period of time is actually after school, before parents get home from their work day. And then you're also thinking about things like transitions to new school environments, so that transition from middle school to high school where the peer group may shift kind of destabilizes some of those protective factors that you see from a community environment. And then childhood sexual abuse is also a known risk factor. We also see high co-occurrence of psychiatric disorders in individuals with substance use disorder. So up to 67% of adolescents with an SUD have had at least one prior psychiatric disorder or diagnosis. Up to 48%, so that's nearly 50% of adolescents with bipolar disorder have a substance use disorder. And then this last statistic here, I'm really seeing a lot of in my own clinic. Up to 46% of individuals with cannabis-induced psychosis may go on to develop a lifelong psychotic disorder. So unfortunately, because of the rising potency of THC products, particularly in vaping devices, so used to be that the patients I was treating were smoking just the plant-based or bud, ranging from about 13 to 15% THC from the cannabis plant. Now I'm treating individuals who are smoking more than 90% THC in their vapes. And when they get psychotic, they can get very psychotic, and that psychosis can be exceptionally challenging to treat. Conversely, when you look at populations of youth, so this here was a study that we did with Boston Children's Hospital in ages 11 to 24. When you look at populations of youth who have a substance use disorder and you work backwards to see is there an association with psychiatric disorders, we find that youth with an opioid use disorder have 3 times the likelihood of also having generalized anxiety disorder. And just a show of hands real quick, anyone work with individuals with opioid use disorder? Couple here. Well, one of the questions that I will often ask is, what was it like the first time you used? And more often than not, I am hearing people describe it was like the world made sense. Like all of a sudden, I felt safe in my own skin, and I wasn't feeling flooded and overwhelmed by everything around me. And when you think about the etiology of that, is that not screaming someone with a generalized anxiety disorder or someone who potentially was struggling with anxiety, and then all of a sudden opioids kind of wrapped around them and formed this safer sense of attachment? So I find it's a really helpful and interesting question to ask. What was it like that first time you used? And you can get a little more information from that question. Then stimulant and cocaine use disorder, so greater than 3 times the likelihood of having PTSD. This is kind of the chicken or the egg. Are you more likely to be exposed to trauma because of your stimulant use, or is there something about the actual stimulant and the response you get from the stimulant in individuals with a trauma history that may be drawing them to it? We don't truly know. And then cannabis use disorder, more than double the odds of having an externalizing behavior disorder. So this would be your ADHD, your oppositional defiant disorder. And we see these associations replicated in the adult literature as well. So again, they're only associations. Screening, so moving right along here. Before you're asking youth about substance use, please review the limits of confidentiality, because what can happen is if you start to ask questions and you get scary answers, you have to break confidentiality when it comes to concerns about immediate or acute safety risk to a parent. And so I've worked with a number of youth who weren't aware that their parents were going to find out about certain information from other providers, and then you end up seeing a mistrust of the system that can unfortunately be lifelong. So whenever I'm screening for substance use in someone younger than the age of 18, I explain the limits of confidentiality before I collect any information. And so I'm talking about, if you are at immediate harm, someone's verbally or not verbally, but sexually or physically abusing you, I go through all of those. But then I also provide substance-specific examples. So if a young person is at very acute or immediate risk of overdose, I outline all of those different types of criteria, and then use in dangerous or potentially lethal situations would be a time in which I would break confidentiality. Other than that, I do not give the who, what, when, where, why to parents, because I want to work with youth and I want them to trust me to disclose information so that I can actually deliver effective treatment. When I'm working with trainees, I have literally a handout that explains all of these items, and I have them go through those with the patient until they start to practice it, because it can be a little uncomfortable talking about the law and what confidentiality means. Here's one of my favorite screening scales. So if you're not familiar with it, this is the CRAFT screening tool. It's freely available online, and I think it might be a little bit hard to read here, but if you look in the bottom left-hand corner, it's the actual acronym of the CRAFT. Have you ever ridden in a car driven by someone who was high or had used substances? Do you ever use alcohol or drugs to relax? So that's the R. Do you ever use when you're alone? Do you ever forget? Family, friends concerned about you, or have you ever gotten into trouble? And so you can very quickly ask those questions. It's evidence-based in adolescent and young adult populations. And then when you look to the right-hand side, this is actually a screening for vaping. Vaping is the bane of my existence when I'm trying to figure out effective treatments, and we'll talk a little bit about that. But it can be incredibly challenging to accurately identify how much nicotine someone is being exposed to when they are vaping, to then do a cross-match to nicotine replacement therapy. But here's a really good standardized screening scale that you can use in younger patient populations in regards to vaping. One of the things I really like about the CRAFT screening tool is that it gives you a handy bar chart for what's the likelihood, based literally off the responses of just the CRAFT acronym, that someone has a DSM-5 substance use disorder diagnosis. And so when I am trying not to break confidentiality in a young person, I will sometimes show the actual CRAFT figure here and say, based on responses by your child on one of our standardized screening tools, they have this likelihood of meeting criteria for a substance use disorder. I'm going to be recommending further evaluation or further treatment, and then I'm not disclosing all of the nitty-gritty details of their substance use unless I feel like it's an immediate safety concern and I need to do so. It's also really important to be screening for sexual history in this population. So more than 1/2 of US adolescents are sexually active by the age of 18. About 30% identify as currently sexually active, and about 1 in 5 or 20% report having used alcohol or other substances during their last sexual encounter. And this is important not only from the risk of victimization in the context of substance use and sexual activity, but also the risk of STIs. So adolescents who use substances are more likely to engage in unprotected sex. Nearly 1/2 of all the STIs in the US occur in individuals between the ages of 15 and 24. And the CDC does recommend annual chlamydia and gonorrhea screening for all sexually active women younger than the age of 25. So we are doing a lot of gonorrhea, chlamydia screening, HIV, high rates of syphilis in my own clinic, and we're offering testing. So moving on to treatment, let's first cover some of the behavioral treatment interventions that can be employed in care. So just from a kind of a high-level overview, when someone is coming into my office, I am taking a kind of a comprehensive evaluation of not just the patient, but the entire family system. So I'm assessing the level of family engagement. How am I going to navigate disclosure, confidentiality? Is this someone younger than 18? Is this a young adult? What results are going to be shared? So we are on the EPIC system, and we have my chart. I can withhold notes and I can withhold, certain aspects of information, but the parents ultimately have access to lab results, which include urine drug screening. And I'm explaining all of this up front. So I'm not going to share details. I'm not going to share my documentation, but your parents are going to be privy to medications, diagnoses, and lab results. And so I just laid out right in the beginning. And then what are the individual levels that are potentially indicated? We'll talk about what are the medication options in this population as well as the therapy. And then I'm also thinking about contingency management planning. And so this is really my opportunity to engage the family system to promote positive behavior change for an adolescent or young adult. And then last but not least, safety. So everyone who comes into my office potentially leaves with naloxone. So we've been able to install a naloxone and fentanyl testing strip vending machine so everybody can access it for free before they leave our clinic. I'm then thinking about alternative modes of transportation. So if this is a young person, say, who's using cannabis daily and they're driving themselves or their younger sibling to school, I'm thinking about safe transportation for that adolescent as well as the sibling. And then any potential reporting concerns. I do see reporting issues come up quite frequently in the patient population I'm working with. And when I'm referring to reporting, I'm talking about involvement of the Department of Children and Family Services. Where are the substances coming from? Are they coming from an adult and they're giving them to this child? Are there any instances of victimization that I need to report? Is the kid safe at home? So I'm doing kind of a comprehensive evaluation to the best of my ability the first time I'm meeting this family. So when thinking about behavioral treatments, there's a wide range, and for those of you who've sat for psychiatry boards, the board questions are always focused on the family-based therapies that unfortunately a lot of people can't access because the family-based therapies tend to be delivered in the community, the ones that are at least the most effective, but they're really expensive and they're hard to bill for. So when I'm thinking about some of the behavioral therapies, I'm thinking about motivational interviewing, CBT, contingency management, which I'll talk a little bit about here in a moment, the family therapies, often office-based because that's what we have available. And then also, what are those recovery supports? What are those community supports and some of those peer-driven mutual supports that they can access? So here's just a quick slide if any of you are interested in more of a cognitive behavioral therapy approach to substance use. So this is the adolescent community reinforcement approach. This is the adolescent manual. There's also a version of this that's called the community reinforcement approach that's been evidence-based in adults for decades. It really integrates CBT, MI, and then this kind of pro-social behavioral approach, meaning if you take away drugs and alcohol and someone doesn't have something to replace it with, what are they going to do? They're going to sit there thinking about drugs and alcohol. So part of it is identifying community-based activities, pro-social activities that can help fill the time that using substances did before. And so it consists of 10 individual, 2-parent, 2-family sessions, and then individual group. And you can see some of the different interventions that they employ. And so if anyone's interested in it, please let me know. There are formalized trainings available, very similar to DBT. Now, contingency management, which is something that I at least attempt to do with all of the families I'm working with. Contingency management is based on operant conditioning. And for those of you who might be familiar with the substance use disorder research world, you may have read articles about the fishbowl. And so the fishbowl is literally a prize bowl where people can have pulls based on some kind of reinforced behavior. So you might see a fishbowl in a methadone clinic where someone is coming for treatment, and if they have a certain number of negative urine drug screens, they get a pull, then they get another pull, and then when you pull out literally a piece of paper, it has some kind of incentive. It might be a MARTA bus card, or it might be a $5 gift card. But the point is it's escalating, and so you get more pulls based on more of the desired behavior. And so there is a reinforcement to it. When working with young people, you have the opportunity to use the family system to create the reinforcer. So I will sit down with families, or I'll have one of the therapists I'm working with sit down with the family, and we'll say, what is something that's reinforcing, so the adolescent or the young adult has to have buy-in, reproducible, so it needs to be available from the family, and then escalating. And so I work with a range of families who are either uninsured, on Medicaid, or have private insurance and are well-resourced. We see an entire range, and it dramatically differs from family to family. But I have a lot of families who identify things like, I want to have increased time with my friends. And every time they either show up to clinic, if that's a desired behavior, or have a negative urine drug screen, they get more and more freedoms. They earn things back. They earn time on their phone or time to the computer. I've had kids earn new shoes. I've also had kids earn new cars. It's kind of whatever the family can make work. But it really shifts the dynamic from taking things away from the child and from constantly punishing them to rewarding positive desired behavior change. And so we're all working towards a shared goal. And I've seen parents and child come in just wanting to fist fight, to now they're working towards something together, and it's just a completely different dynamic. So we do this with every family that comes into the clinic. And then I also don't want to forget about recovery supports, and these can differ by community and what resources you have available, but there's also some national resources as well. There are young adult peer support options as well as self-help meetings. I refer a lot of my patients to Smart Recovery, which is freely available online. It's more of a CBT-based mutual support group versus a 12-step, which would be AA or NA, although I also refer to those types of meetings. And then something to think about would be your collegiate recovery programs and communities, so your CRCs and your CRPs. So your CRCs are communities on college campuses that are mostly peer-led, often with the support of maybe a faculty advisor, who are providing just an outlet for people who are in recovery or trying not to use drugs or alcohol to get together on a college campus. CRPs, or collegiate recovery programs, are more structured, formalized, and you often find additional access to services on campus, potentially substance-free housing, and then even individual or group counseling. So Kennesaw State has one of the nation's best CRPs and longest-standing CRPs. So if you're thinking about a young person who wants to go to college, or maybe it's a young adult or someone in their early 30s who wants to go back to school, that could be a really good avenue for them. And then also considering Alateen. So we work with a lot of families where the parents or the guardians or caregivers have a substance use disorder and the young person has a substance use disorder. So not forgetting that the young person is still living within a dynamic of having someone else in the household using drugs and alcohol around them. So 1 in 8 children in the United States lives with a parent who has a substance use disorder. So not forgetting that you need to be providing individual supports based on their own needs and their own substance use disorder, but things like Alateen help provide them the supports to live with a family member who also may be using drugs and alcohol. All right, everyone still with me? Can I get like a kind of a nod? Yeah? All right. So now we're going to be focusing on medications. So let's take a look at alcohol use disorder first. One of the things I've highlighted in red on these slides are the numbers of people enrolled in the studies. And so what I am about to present is more lack of data than substantial data. So if any of you are interested in getting into research, this is a wide open field because we have very few well-powered studies looking at young people and treatment of substance use. So when it comes to naltrexone, so for those of you not familiar with the treatments for alcohol use disorder, we have 3 FDA-approved medications for the treatment of alcohol use disorder in adults, naltrexone being one of them. It's an opioid antagonist, and it's FDA approved for alcohol and opioid use disorder. It is not FDA approved for use in pediatric populations. The one study that we have has an N of 22, looking at ages 15 to 19. It did demonstrate some improvement in drinking, but it wasn't necessarily robust. Then there's antabuse or disulfiram, which is also an FDA-approved medication in adults that blocks or stops the breakdown or the metabolism of alcohol, and it creates these noxious metabolites that literally make people very, very sick. And they can start vomiting even if they inhale alcohol fumes. There was one study with an N of 26 looking at ages 16 to 19, and it did show pretty robust reduction in drinking and increase in days abstinent. I've never prescribed this medication to an adolescent. I find it a little ethically questionable because the protocol typically for disulfiram in adults is someone else is administering the medication. So you're thinking about a parent or guardian administering medication that is potentially going to make that child very ill. And so I try to stay away from that dynamic if at all possible, but there is some supporting data for its use. Now, the third medication that's FDA approved in adults is acamprosate, which is a medication, it's an NMDA receptor modulator, but it's a medication that is approved for 3 times daily, so you have to take it 3 times a day. And the only study that was done in youth, so those younger than 18, was retracted for copyright violation. So it's literally the only study we have on acamprosate in young people. It had some good data, but I have no idea how to interpret it because I don't really know how they had a copyright violation and it was retracted. Then there's another study of ondansetron, so you might know it as Zofran, a medication to help with nausea and vomiting. It's also a serotonin antagonist. This had an N of 12, so very small number. It was well tolerated, maybe helped a little bit, but it is certainly not going to be one of my first-line treatment options. I do just want to call out monitoring. So one of the approaches to care in young people is often knowing if they're using substances. So as far as monitoring for alcohol use, you can collect metabolites of alcohol, so ETG, ETS, and those will be positive in, say, a urine drug screen for about 3 to 4 days after use, but they do not correlate to the amount consumed, so I use it as a yes/no. There's also really interesting breathalyzer apps where you can download an actual app and breathe into it, and it records your face, so you know it's you. I will typically only recommend these types of apps if the adolescent or young person is earning privileges, meaning they have been grounded, they haven't been able to leave the house, or maybe they want to go back to college and they're looking for their parents' support. I might recommend one of these apps to kind of alleviate concerns and have them have the ability to demonstrate that they're not drinking. I'm often not trying to get my young people into trouble, but it can be something to advocate that they can be in an external environment and still prove that they're not drinking. And then there's also phosphatidylethanol, which is PEth testing, which is a marker of heavy drinking that we can now detect by blood a month out after a heavy drinking episode. This is a blood draw, and I very rarely will use it in younger patients. I've done it a few times, basically at the request of the young person to prove to their parent or guardian that they have not been drinking, but because it's a blood test, it's invasive. It's not something that I typically mandate in care. And then I just wanted to call out practical suggestions because I basically presented no data. There's not a lot out there. Our studies are completely underpowered. Personally, when I am treating someone who's under the age of 18, I do use a lot of naltrexone. We have great safety data for naltrexone in studies looking at naltrexone in opioid use disorder for youth. It is not FDA approved. This is completely off-label. There's only one medication for addiction treatment that is FDA approved for minors, and that's buprenorphine for opioid use disorder. So I want to be really clear, any of these recommendations I'm making are completely off-label because we do not have FDA approval. We don't have great data. I'm just sharing what I clinically do myself. I will often use naltrexone. I typically start with a lower dose. So if you're going to be dosing oral naltrexone, comes usually in just a 50 milligram tab. I will often start at 12.5 in a young person because they tend to get nausea from this medication much more easily than some of our older adult populations. Then for naltrexone ER, so the monthly injection, which is an IM injection, which I'll tell you a lot of my adolescents do not like a gluteal IM injection. It's the same dose as adults. I rarely will use acamprosate. That's that medication that's dosed 3 times a day. I have difficulty getting adolescents to take 1 pill once a day, let alone consistently taking it 3 times a day. I do not use disulfiram in this population. And you could consider gabapentin. There is some data for gabapentin in older adults for alcohol use disorder. There aren't any studies in young people, which is why I did not present it. But there's really good safety data for gabapentin in young people, particularly because of epilepsy and seizure disorder studies. So it is an option here. All right, moving on to cannabis use disorder. I'm actually excited to present this slide because it's one of the few studies that we have that is actually reasonably robust and decently well-powered. So this is N-acetylcysteine. Can I just get a quick show of hands? Who's familiar with NAC? Okay, so a few people. So NAC, it's been used for kind of a range of psychiatric disorders, but it's most well known for its use in the case of acetaminophen or Tylenol overdose as a liver protectant. So it's an antioxidant. It used to be over the counter, but it's actually now only by prescription, but Amazon and most pharmacies haven't caught on to that, so you can still buy it online. But N-acetylcysteine, the thought here is that it helps to kind of regulate and modulate glutamate, which then is implicated in restoring dopaminergic function. And in the case of cannabis use disorder, N-acetylcysteine more than doubles the likelihood of abstinence in individuals ages 15 to 21. And so that's dosed at 1,200 milligrams twice daily. Very few side effects except acid reflux, which is legit, and the pill is huge. So I get a lot of complaints about it. But this is really good data here. We have very few effective treatments for cannabis use disorder. For some reason, it stops working at the age of 21. Everyone got really excited about this study, which was conducted out of MUSC with Dr. Kevin Gray. And so there was a large multi-site study that recruited all of these adults ages 18 to 21, and they were really hoping to see an effect of N-acetylcysteine on cannabis use in older adults, and they saw nada. They saw nothing. There was no effect. They went back to that study and they pulled out the 18 to 21-year-olds, and they replicated the same odds ratio, which was 2.4. Again, in that age group, it more than doubled the likelihood of abstinence from cannabis. But for some reason, it stops at the age of 21. So there's some thought, and I've talked with Kevin or Dr. Gray, who's the author of this study, the lead author. They don't know why, but they think that there's some solidification of the neural networks of maybe the prefrontal cortex by the age of 21. Don't forget that the full maturation isn't until much older than that, but maybe at the age of 21, it just stops working. So when someone turns 21, I just stop it. But for those that are ages 15 to 21, I use it all the time. Again, off-label. For cannabis use disorder monitoring, just a couple call-outs here. So I used to not have my parents or guardians do home monitoring because there's just something awkward about collecting urine from your kid, and it just creates this dynamic. And then the pandemic hit, and I completely softened on it. And so now I have a lot of families that are doing home monitoring. My preference is often to take over that. It's important to note that if you're going to be using a home urine drug screen, oftentimes the threshold for detection is 50 nanograms per milliliter. Cannabis is extremely sensitive to fluid washout, meaning if you're looking at levels and you're looking at them from a clinical perspective, you want to adjust for urine creatinine. So in the clinic, I never read a THC level that's not been adjusted for urine creatinine, because if someone's fluid overloaded, they can really wash those levels down. And if someone's dehydrated, they can falsely elevate. And you can then potentially accuse someone of using cannabis, especially if you're doing something like weekly urine drug screens, because they have a spike because they're dehydrated 1 week, when they're not actually using. So I always adjust for urine creatinine, know that someone can be using once a week, especially if it's a plant-based actual from the cannabis plant, lower potency THC, they could be using weekly and not get above 50, especially if they stay hydrated. And then I'm also finding the time-old tale was you'll wash out cannabis within a month. Well, I'm now seeing levels that are so high that I can't even identify them on our urine drug screens. They're greater than 2,000. I used to see, levels of 400 to 500 in someone who was smoking a blunt a day. But now, because of the high potency THC products, I can't even register the levels. And I'm finding it's just taking significantly longer for them to get out of a person's system. So just because it's positive beyond a month, especially if you're using a point of care that's more like a yes, no, it's in the system, it's not, or in the urine, they may not actually be using. And then when we complicate it with analogs like your delta 8s, your delta 10s, your THCOs, I's, A's, anything you could think of. That's where it becomes really tricky because most urine drug screens are made in a way that they identify delta 9 if it's like a quantitative GCMS study. If it's a point of care, they're going to detect anything that potentially cross-reacts or looks like it. So this becomes problematic when I have someone who's using delta 8 or delta 10, which is an analog of THC9, which comes from a plant. You can buy these in gas stations. They will test positive on a point of care because point of care is meant to detect anything that looks like THC. They will test negative for anything if I do a send out confirmation test because that is looking for delta 9. It's not looking for everything else. And so the urine drug screens get really confusing, especially if someone's on probation. I'm often working with a lot of probation officers to try to justify why a urine drug screen might have been negative or positive in different areas. So opioid use disorder, and I have a few slides on this. I'm going to move relatively quickly. I already mentioned that buprenorphine is the only FDA-approved medication for addiction treatment in anyone younger than 18. There's actually pretty robust data. I did not highlight the N in red for this one because it had an N of 152. It was adequately powered. And so really the goal here is that we're using buprenorphine in youth with opioid use disorder, not just for detox or detoxification, but actually for maintenance treatment. And we have a lot of data to support that. So not trying to stop the medication too early in youth. You really should be continuing it for as long as they're willing to take it because we don't have any evidence to tell us when to stop it yet. We're looking, we just don't have it yet. Often I do find that my younger people, even if they're injecting heroin or sometimes fentanyl, will quite often surprisingly need lower doses. So I will often start lower with buprenorphine for my younger people as compared to my older people, but you always titrate to effect. So you titrate to withdrawal of symptoms, or sorry, to treat withdrawal so they don't have any symptoms of withdrawal, as well as treating to cravings, meaning you don't want them to have any cravings for opioids. So I have a complete range of what patients end up on. There's also pretty extensive data of the injectable naltrexone. So this is an opioid blocker again. It's FDA approved for alcohol opioid use disorders, has pretty robust studies for Vivitrol or extended naltrexone in youth. Mark Fishman's done a lot of this research, and it's been reasonably well tolerated. And for those who stay on it, they have remarkable reductions of opioid use. But the issue is that young people hate getting an IM injection. It's like getting them to agree to immunizations every month for the rest of their life. Like they just don't want to do it. So they've done studies where they've actually employed naltrexone vans, and they'll find kids or young people at like McDonald's and give them the IM injection there. And aggressive, assertive outreach for extended release naltrexone improves rates, but they're still not great. So here, this was a study of 288 young people with opioid use disorder, ages 15 to 21. Of the 82 who were randomized to 6 months of monthly injections, only 2 received all of the injections. So it's gonna be really hard to get them to come back for these injections. Methadone is what we call a fail-first medication in young people, so those younger than age 18. There's some restrictions about needing to unsuccessfully complete other treatment approaches before you're allowed to be eligible for methadone if you're under the age of 18, and often you need some kind of parent or guardian consent before the clinic would allow you to be dosing methadone, which is a full opioid agonist. There's very few controlled studies. One of the last ones was actually in the 1970s, but it had decent data. It wasn't a very well thought out study though. As far as opioid withdrawal, the recommendation here is to be using medication like buprenorphine, which is a partial opioid agonist, over supportive measures like clonidine, which is an alpha-2 agonist. And so here, this was a study that was actually pretty interesting. So they used buprenorphine over clonidine for just medically managed detoxification. So the goal wasn't to keep the kid on buprenorphine, it's actually to transition them to naltrexone, which is more widely accepted within kind of younger people because it's an opioid antagonist and there's this belief that they'll be addicted to buprenorphine for forever. So you do find that parents and young people prefer naltrexone, even though getting them on the injection is really hard to do and getting them to stay on it. But this was a study that looked at buprenorphine for just treatment of withdrawal symptoms versus something like clonidine, and you are much more likely to engage a young person in treatment if they receive buprenorphine than if they receive something like clonidine, because you're doing a better job managing their symptoms of withdrawal, managing their cravings, and keeping them engaged in the treatment plan, even if the plan is not to keep them on buprenorphine. So if you're treating any withdrawal, I encourage you to use something like buprenorphine versus clonidine. And then kratom. Kratom. Anyone see kratom here? Yeah, so you can buy kratom in a gas station. So kratom is actually really interesting, and it's similar in its pharmacologic profile to buprenorphine. So it's a partial mu agonist, and it's a kappa antagonist, which is what buprenorphine is. It's illegal here in the state of Georgia over the age of 18. You can buy it in gas stations. You can test for it on urine drug screens if you're looking for the metabolite mitragynine, and it has a range of different side effects. I will often see my patients using kratom to self-manage symptoms of opioid withdrawal, or they're just using it to also potentially get high, although it does not cause as much of a high as full agonist opioids. There's no specific data on treatment in adolescents. Really, the recommended approach is to treat it like an opioid use disorder and to use something like buprenorphine or naltrexone. But most of the data for that comes from adults, not for young people. And then I want to call out overdose here. So we are still seeing rising rates of overdose, particularly in our young people. Overdoses are now responsible for 12% of deaths in those ages 15 to 24. Naloxone, which is an opioid overdose reversal agent, it's often administered intranasally, is approved by the FDA for all pediatric ages. And I give naloxone out to everybody I possibly can because many of these overdoses are unintentional, where the young person thought that they were using something like Adderall and it was pressed with fentanyl, which is a high-potency opioid. So anyone who's using substances, I give naloxone out to. And then I do a lot of counseling that if you use your first dose of naloxone, it has a really short half-life, the person could re-overdose, and you've just used your only kit of naloxone. You've got to get to the ED, because oftentimes whatever the person used is going to last longer than naloxone, and they re-overdose and you're out of naloxone. There's also here in the state of Georgia, we have Good Samaritan laws and amnesty laws. So I do a lot of counseling because kids don't like to get in trouble, that if someone calls 911 to get an ambulance because someone just OD'd, you're all not going to jail. You can't be arrested for personal possession in a quantity for personal use of substances or paraphernalia in the vicinity of someone that you've called 911 for an overdose. So I do a lot of counseling about call 911. Don't be afraid to do that. I can't guarantee you won't get in trouble from your parents, but it won't be the law. We do still have pretty significant disparities as far as access to treatment for young people with opioid use disorder. So on the left-hand side, you're looking at based on population prevalence, so only about 3.6% of adolescents with an opioid use disorder will get treatment in any 1 year. And then when they do get treatment, only about 2% have medication for opioid use disorder, which is the evidence base, as part of their treatment plan. So we have a long ways to go to make sure that young people actually have access to care or effective care. You can also see that there's some disparities for young adults, which is that middle bar as well. My team did a study here in Georgia where we surveyed all of the addiction treatment facilities, the licensed one here in the state, and we got a lot of answers about what are the perceptions of medication for opioid use disorder in young people, so young people ages 16 to 18, 18 to 25, and then older. We had over 200 respondents from over 70 treatment facilities, and we had 1,400 responses. Like, people really felt passionately about this. But what we saw were that there was really the belief, especially here in Georgia, that medications for young people should not be used in the context of opioid use disorder because it's replacing one addiction with another, and that there's a mistrust of these medications because we don't know what they're going to do long term. So here's one of the quotes from one of the respondents, that I think medication should be the last resort after other treatment methods have failed with regards to adolescents. One of the problems with this is that adolescents might die before they receive effective treatment. So I encourage you to think of things like buprenorphine and even naltrexone as first-line options. So quickly here, nicotine use disorder, and then we're almost done. So nicotine use disorder is really hard to treat in younger patients. So the rates of remission are actually lower in those who are attempting to quit, so sustained remission, than in adults. So only 10% of those who've attempted to quit refrain from smoking at 6 months. I often will do a lot of nicotine replacement therapy. Keep in mind you need to prescribe it. Someone under the age of 18 cannot pick it up over the counter unless their parent or guardian does so. There's some short-term evidence for the patch, not a lot for the gum. I'm still doing combination patch and gum for most of the patients that I see. And then there's a number of behavioral strategies. On the bottom right, I do want to call out the text ditch vape to 88709. This is from the Truth Initiative. It actually has pretty decent data. It's designed as a text line to help young people quit vaping and using cigarettes. And it has actually decent data. It's completely free. As far as nicotine use disorder for medications, there's decent data for bupropion, so the trade name would be Wellbutrin, NDRI, in the same doses as adults. So this is one where I would be using something like 300 milligrams per day. The studies, when you combine them, we have 4 RCTs, actually demonstrate that it does improve rates of abstinence. For smoking cigarettes, varenicline or Chantix doesn't have great data. Kevin Gray, again out of MUSC, has attempted a couple RCTs for that didn't quite work out. But what we've recently seen is that there was a study published just a couple weeks ago, so I had to update my slides and resubmit them. Thank you, Andrew. But there was a study that was just published a couple weeks ago looking at varenicline, which is Chantix, for nicotine vaping, and is the first randomized control trial. We've been waiting for this for a while. And it really demonstrated positive results for varenicline or Chantix for vaping cessation versus placebo. And they did use the Truth Initiative, that text ditch vape line that I just showed you on the last slide. They used this in combination with all of the other arms. So they had a varenicline, a placebo, and an enhanced usual care. So I think based on this study, I'm likely going to be using varenicline more often in my adolescents who've been vaping. And they included ages 16 to 25. And then safety, we already started to touch on this. Youth with higher psychiatric comorbidity, they're more likely to overdose, they're more likely to self-injure and attempt suicide. But what's really interesting on this right-hand side, this was a study published in 2024, there's a dose-dependent relationship with substances, including alcohol, cannabis, and nicotine, based on the frequency in which you're using and the percentage of having suicidal thoughts. And so when you're thinking about whether or not harm reduction should be applied to young people, I'm a huge advocate of harm reduction because not everyone I treat is looking for abstinence. And so this here really supports that if you can help get someone from daily or near daily to weekly use or monthly use, you're dramatically reducing their risk of suicidal thoughts and potential suicide attempts. So this really supports that. And then fentanyl testing strips, I mentioned we have a vending machine where we do promote fentanyl testing. This is actually from a website called Dance Safe, and so you can purchase these informational guides and actually have them in your clinic, or you can get them freely online. But we purchase our fentanyl testing strips from them. All right, we made it. We did it. So just to summarize real quick here, young adults have really high rates of substance use disorders, about 1 in 4 to 1 in 3 young adults have an active substance use disorder in the last 12 months. That transition from adolescence, where you've got about 8% of adolescents having an SUD, to young adulthood is a pivotal period of early intervention if you can provide that. There's a high co-occurrence with mental health disorders, thinking about some of those associations that we walked through. Please talk about confidentiality for your young people so you don't foster a sense of mistrust in the system. Integrate the family where possible. We didn't have time to go into great detail about this, but when you're able to involve the family, treatment outcomes often improve. And then contingency management plans, please consider those. They can be implemented by the family. You don't have to have a personal fishbowl, pull prize kind of thing. And then just for our medications, I talked a lot about off-label medications. Buprenorphine is FDA approved for ages 16 and older. Naltrexone is not FDA approved, but it does have decent safety data. I will often use it in my patients with alcohol use disorder. I will also use it in the context of opioid use disorder, hopefully on the long-acting injectable, because that increases rates of adherence, but most adolescents don't really like that. Consider N-acetylcysteine for cannabis use. The data stops at the age of 21. Don't really have much signal past that. And then combination of nicotine replacement therapy, behavioral interventions. And I needed to update this point, and I didn't, based on that study that was published about 2 weeks ago. Varenicline could be an option there. And that's it. We made it.
Thank you, Dr. Welsh. If you're viewing online and have a question, please put it into the Q&A section and we'll ask that for you. But in the room, do we have any questions or comments for Dr. Welsh?
I think we have a question over there. Yeah.
Hi, so I'm Dr. Silverstein, a PGY2 resident. At least when I was on my child to adolescent rotation, it felt like marijuana was just the norm in patients rather than, you know, something you wouldn't expect to see as much. And since they're kind of already using it and prevention's not really an option at that point, it's hard to talk to them about it because they're like, oh, well, it's good for my anxiety and sleep. And it almost feels like an uphill battle trying to be like, hey, no, there's risk. This isn't as healthy and safe as, you know, it's made out to be, and kind of how to start to change their mind about, hey, maybe this actually isn't the greatest thing for me to use, and like how you kind of tackle that.
Yeah, so it can be challenging to really shift the perception of the risk and the safety in one moment. I do find that young people respond well to the facts. So instead of me lecturing them as an adult, like, hey, smoking is bad for you, using cannabis or vaping nicotine is bad for you, I will often just actually show them like pictures of PET scans or fMRIs, and we'll look through what are the changes that actually occur in the brain from a neurobiological perspective. And that it's not me lecturing of what's good, what's bad, with what's ethically wrong or immoral. It's no, this is actually what happens over time as people are exposed. And I do it from a motivational interviewing framework where I will ask permission before I'm sharing what I know. And if they say no, then I actually back off because they're not ready to receive or hear what I have to say anyways. So that's just my initial thought to that.
Hi, Dr. Welsh. I'm Chelsea Cleveland, a third-year psychiatry resident. So psychedelics have had some research being studied for adults with substance use disorder. Do you think that they'll ever play a role with adolescents, or is the developmental risk too high for them?
That is an excellent question. So what I will say is, if they do make their way to young people, it's going to be some years because I presented the naltrexone data that's been around for forever, and we still barely have any studies in youth. So I actually hope that maybe one day we will. And I think that there's a fear of investigating new and novel treatments for young people when there's honestly a need for it. And as long as we can demonstrate safety, before we start doing some of the efficacy studies, and then I support it, but we really have to establish that safety threshold before we start to apply. But some of the data in adults is pretty promising, so I'm not going to completely rule it out.
Hi, I'm Amanda Hendricks. I'm a PGY3 resident. And I had a question about, so I know that there's been talks about federal cuts to funding for Narcan. And I've seen things more so talking about how that may affect adults, but I wanted to know your thoughts on it. Have any of your patients been affected, or from a clinical standpoint, how you've been navigating that?
Yeah, Narcan is expensive. It's really expensive. So our wholesale cost, I don't know, Emery might not like me saying this, but our wholesale cost it's $33 for a box that has a kit of two actual dosages. It's expensive. And I would say one of the nice things here about this in the state of Georgia is that we do have the opioid settlement, opioid abatement dollars that are now flowing through, so over $600 million over the next, like 19 years or so. So I think that here in Georgia, we're going to be able to kind of boost our own internal supply of naloxone and Narcan. But yes, any kind of budget cuts to addiction treatment, to recovery supports, to overdose prevention potentially can impact our patient population. Now, we have a naloxone vending machine that's actually supported by philanthropic support. So we've done a lot of fundraising. We've been applying for grants to keep that operational. So my personal patients haven't been impacted because I give it to everyone I see for free. But yes, I suspect there might be an impact. Hopefully not too much in our state.
Great talk. This was really fascinating. I'm a child and adolescent psychiatrist here. But my question is, we see a lot of ADHD, and how do you address ADHD in this population?
Oh my goodness, that is
On talk.
That's like a 4-hour talk in itself. I treat a lot of ADHD. There's the high co-occurrence of ADHD and substance use disorder diagnoses. So first of all, it's getting an accurate diagnosis, often based on collateral support, timeline of using. The question I always get is to increase the stimulant or not to increase the stimulant when someone is oftentimes using cannabis at very high potency or with the high frequency. I try not to treat cannabis use with the stimulant, but also knowing that undertreated ADHD increases the likelihood of ongoing substance use. And so it's always that balance of trying to identify, are these truly ADHD symptoms, or is this some kind of functional prefrontal impairment because of cannabis use? And again, it goes along with the collateral history. I personally am more likely to err on the side of treatment because I'm more worried about undertreating the ADHD than I am overtreating the ADHD. I have had some patients where we've increased the stimulant dose, and we've been able to back down on it when they've actually had a full period of abstinence for a number of months. But I'm more likely to be aggressive with my ADHD management. And then I also employ a lot of kind of safety precautions. If it's someone with a history of a stimulant use disorder, I'm doing what I can to mitigate risk of diversion and misuse. I'm more likely to use long-acting stimulants versus short-acting stimulants. Things like Concerta, harder to snort because the polymer matrix, it turns into a goo when you actually insufflate it. So I'm thinking about what are the things that I can do to reduce the risk for my patient while actually treating their ADHD. But it's not easy. Yeah, great question.
Thank you, Dr. Welsh.
Thank you, everybody.